Hi, I'm Lucy Davies, and this is a one-off special podcast from Room for Improvement, the podcast dedicated to service improvement in axial SpA care. I'm flying solo hosting today's podcast, but I'm delighted to be joined by two incredibly talented clinicians to discuss unravelling the hidden complexities of acute anterior uveitis. As usual, we'll be talking to our guests about their experiences and taking a deep dive into strategies and techniques that they've used to push towards success. So welcome to our one-off special episode of Room for Improvement, which is focusing on ophthalmology and uveitis. Many people with axial SpA have uveitis or eye inflammation. So today we are joined by Dr. Nima Ghadiri, who is a consultant medical ophthalmologist at Liverpool University Hospitals NHS Trust and an honorary senior clinical lecturer at the University of Liverpool. Welcome, Nima.
Thank you very much, Lucy.
And I'm delighted that we've also got with us Professor Karl Gaffney, who is the consultant rheumatologist, research and axial SpA service lead at Norfolk and Norwich University Hospitals NHS Foundation Trust, and the president of British Society for Spondyloarthritis. Welcome, Karl.
Thank you very much, Lucy. Hi, Nima. It's great to be here.
I'm delighted that both Karl and Nima have been working together to raise awareness and knowledge for ophthalmologists. So without further ado, let's get our teeth into the challenges around axial SpA and the eyes and unravel what the eye is telling us. Karl, do you want to kick off and tell us a little bit about the rheumatology view on the problem?
Yeah, thank you, Lucy. I'd just like to start by giving a very brief overview of what we mean by spondyloarthritis. So spondyloarthritis is a term that embraces a group of conditions which are typically characterized by inflammation of the spine. So spondyloarthritis, that's straightforward. Now, these diseases can arbitrarily be divided into peripheral and axial disease, whereby if they have predominantly axial symptoms, in other words, back pain, we call it axial spondyloarthritis. If the disease is mostly peripheral symptoms like swollen joints, peripheral arthritis, we call it peripheral arthritis, and that's usually related to psoriasis. But for patients with axial spondyloarthritis, we used to call that ankylosing spondylitis, but it's been rebranded now as axial spondyloarthritis or AxSpA or Axial SpA. So there are numbers of terms that are interchangeable, but the correct terminology is axial spondyloarthritis. So patients with axial spondyloarthritis can then be further subdivided based upon X-ray and MRI. If they've got positive X-ray with structural damage, we call that radiographic axial spondyloarthritis, which is the same as ankylosing spondylitis. But then there's an equal group in terms of numerical group who've got what we call non-radiographic axial spondyloarthritis, meaning it's the same disease. They don't have structural changes on X-ray, but they've got characteristic inflammatory changes on MRI. We call it bone marrow edema. So it's. I don't think we've done ourselves any favor here in terms of the terminology. That a lot of the terms are almost pronounceable and difficult for people to remember. So I think the easiest way to say is it's SPA is the umbrella term. AxSpA is if it's predominantly spinal. Out of the water with ankylosing spondylitis, really, unless people want to use it, but the correct terminology is AxSpA or axial spondyloarthritis. Hopefully that makes sense. So as you may or may not know, axial spondyloarthritis is one of the commonest forms or types of inflammatory arthritis that affects about 0.5% of the population. So we're talking about 1 in 200 people. Typically, it begins in early adult life. The mean age of onset is around 30, which is quite different from other types of inflammatory arthritis. This type of inflammatory arthritis is part of a family of diseases, which includes uveitis, inflammatory bowel disease, and psoriasis. So there's often an overlap. So for patients with axial spondyloarthritis who typically present with back pain, approximately 1 in 3 will have an extra musculoskeletal manifestation, meaning they'll have an inflammatory disease affecting another part of their body. The commonest association is with uveitis, whereby approximately 1 in 4 patients with axial spondyloarthritis will have or will develop uveitis during the course of the disease. And the risk of them developing uveitis increases with increasing disease duration. So it can begin at the beginning. It can precede the onset of the back disease, or it can begin 20 or 25 years later. So we see it across the whole spectrum. It can be unilateral, bilateral, recurrent, or not. And I'm sure Nima will go into that in some more detail later. But from my perspective, the importance of this association is multifactorial. Firstly, as a rheumatologist, knowing that a patient's got uveitis adds another layer of complexity to the disease, both in terms of its management and selection of appropriate therapy for that patient. But more importantly, as someone who's been trying to drive down the diagnostic delay for this disease, which currently stands at 8 years, I see the presence of, or the development of uveitis as an opportunity to funnel patients through from ophthalmology clinics to rheumatology, where we'll be able to establish that diagnosis. So as I said, many patients present with uveitis or present to emergency eye departments or to ophthalmology clinics who've got this disease but actually don't know they have it. So from my perspective, it's really important that we raise awareness of axial spondyloarthritis amongst ophthalmologists so they can channel patients through to us, and hopefully we can establish a disease and offer patients the treatment that they need and deserve. I don't know whether I've kind of explained that succinctly enough, Lucy, but if you want me to elaborate on any aspect of that, I'm happy to do so.
Fascinating to hear those numbers actually, and the amount of people presenting actually with that extra.
We call it extra musculoskeletal manifestation. It's a bit confusing. It used to be called an extra articular, meaning outside of the joint. Now it's called extra musculoskeletal, meaning outside the musculoskeletal system. Yeah. So it's a terminology challenge.
Yes, definitely want to quite get your teeth round, I think. Nima, do you want to give us your perspective on that sort of challenge that we have around axial SpA and the eyes from your perspective as an ophthalmologist?
Exactly as Karl alluded to there, around a third to probably 40% of patients with ankylosing spondylitis do develop uveitis. Uveitis in general as a condition, it's a challenging one. It affects in the UK around 5 to 10,000 people, but there's just a huge host of potential causes of uveitis. And we can subdivide it into different kind of anatomical distributions, the front of the eye, the middle, the back of the eye, or various layers of the eye. By far the most common area of the eye which can get inflamed is anterior uveitis, and by far the most prevalent link is with ankylosing spondylitis. So that's why, for me, it's very important to work with rheumatologists such as Karl and my colleagues locally here in Liverpool, and make sure that we're asking for other symptoms and effectively co-managing these patients, because uveitis it's a challenging one to diagnose. Sometimes patients might see a red eye, or the practitioners who manage them and think that it might be something else, such as conjunctivitis or an infection in the eye, and not quite get the features that we see in our eye clinics, which are suggested that this might be uveitis. And as a result, then there can be a delay to treatment and greater likelihood of complications with this condition. Uveitis effectively means inflammation of the eye, and the patients will come in with redness, with pain, with sensitivity to light, that's called photophobia, sometimes with floaters if the inflammatory cells spill in the middle of the eye, and sometimes with headaches or eye strain. So there are other eye conditions which can have some of those features, but it really does need a good history and examination to be able to diagnose it. And the patients I see who we diagnose uveitis with, we get to know them sometimes pretty well, because they can map out their flares and the course of their disease, and they'll know often what can trigger an inflammatory bout, what specifically for them improves things. And then we follow a course of treatment for these patients, starting with conservative things such as drops, steroid drops, and drops which make the pupil larger, drops which have the goal of relieving pain, and then going up a ladder of treatment. Potential complications of the eye, such as raised pressure, which can lead to glaucoma, cataracts, membranes in the back of the eye, fluid which builds in the back of the eye, and complications due to low pressures. So we really, from a uveitis, from an eye perspective, do need to be seeing these patients and diagnosing them early, and then obviously asking the questions to help the diagnosis where there may be a link to ankylosing spondylitis.
Thanks both so much for the summary. So really be good to get into some of the challenge and understand that in a deeper way. Nima, could you tell us a little bit about acute anterior uveitis and why it's linked to axial SpA?
Yes, so uveitis, we can split it up into different parts of the eye. So anterior uveitis is the most common. 85% of patients with uveitis have inflammation in the front of the eye, anterior. And in AxSpA, 90% of patients present with anterior uveitis, 90% acute rather than chronic. So kind of grumbling in the background is what we consider to be chronic. 90% have it as an acute flare. And it's usually in one eye, in around 90% of patients. And in almost half of them, there will be a recurrent uveitis, so the uveitis will come back again. Only very rarely does the uveitis affect both eyes at the same time. It tends to affect one eye at a time. Sometimes there's a preponderance for one eye over the other, but it's usually in one eye at the time. And in around half of patients with anterior uveitis, it's associated with this allele, the human leukocyte antigen B27, HLA B27, which is the locus which predisposes people to AxSpA, to all the extra articular manifestations that we've talked about so far. So within patients who've got a diagnosis of AxSpA, around 1/3 to 40% will have that manifestation of anterior acute uveitis, or AAU. So it is within uveitis the strongest link with a systemic manifestation, AxSpA and uveitis.
Thank you. Really interesting to hear some of the technical there. Karl, do you want to add anything more?
Well, just a couple of other sort of insights, I think, Lucy. Prevalence of HLA B27 in the population in the UK, we have this data for the Caucasian population, but not for all ethnicities, is about 8%. So there are a lot of people out there who are HLA B27 positive. And that's a susceptibility pointer for a number of diseases, including uveitis and axial spondyloarthritis. So, for example, in axial spondyloarthritis, about 85% of patients will carry the gene. So it's about, it's highly associated. And the association with uveitis is a little bit less, but it's still high. So being B27 positive is part of the story. But then if it's a systemic inflammatory disease, then why do people get inflammation at certain points in their body or certain areas and not in others? Like, you don't tend to get multi-organ involvement, and you don't often get lung involvement or cardiac involvement. So one of the theories is that the key histopathological hallmark of this disease is called enthesitis, which is inflammation of the attachment of ligaments and tendons to bone. So typically kind of at pressure points. So, for example, animal models where you suspend rats and don't allow them to exert any direct pressure, if they're B27 transgenic mice who are exposed to certain infections, they don't get spondyloarthritis. So when they're suspended, they don't. But if you place them down on a surface, they do. So pressure seems to be in a point. So, the diseases that are associated with spondyloarthritis often affect pressure points. Psoriasis affects pressure points, elbows, knees, occiput. Colitis, it's the terminal bowel. The ileocolic valve is an area of pressure. And my understanding is that the iris and the ciliary body, which are part of the anterior uveal tract, are high pressure points in the eye. So it's a kind of a multifactorial pathobiology with a genetic susceptibility, inflammatory disease. We don't know what provokes it, perhaps infection. And then you've got this predilection for pressure points. So it's kind of really interesting. I don't know what that's a very rheumatological take on the anatomy of the eye. I may not have conferred that accurately, Nima. I'd be interested in your take on pressure within the anterior chamber.
Yeah, from my perspective, that's what I understand to be the theory. So I've got nothing to say in disagreement to that.
It's plausible anyway.
Yeah.
So thank you both for that. It's really interesting. And what I think I'm hearing from you is that we can in both settings, both rheumatology and in ophthalmology, a patient could present with one or the other condition and it may not be diagnosed. So we could see patients coming into our ophthalmology clinics with an undiagnosed axial SpA. Potentially, then we could also see patients going into an axial SpA clinic in rheumatology with an undiagnosed uveitis. So the key here is really trying to unlock and understand between those two specialties. Is that a fair summary?
Absolutely, Lucy. It's about collaboration. And I think it's the sort of thing we should be promoting at a national level, but also at a local level. Like, we can work very closely with as a rheumatologist, with our uveitis specialists to ensure that this flow happens in a fairly seamless fashion and make it as simple as possible for our patients. And in fact, there have been a number of studies, I don't know whether this is the time to bring this in, looking at kind of referral strategies, Lucy. And there are three that come to mind. One's called the Dublin Uveitis Tool. Another one was called the Sentinel Study. And we did one in Norwich called the SpA study, which is Axial Spondylitis with anterior uveitis. That's the acronym. So we looked at every patient who'd come to the uveitis clinic over a 1-year period. And, a number of those had a pre-existing diagnosis of axial spondyloarthritis. But there were 77 who had self-reported chronic back pain, but no verified diagnosis, because that had never been considered. And of that group, 25 of them had undiagnosed, 25% of them, had undiagnosed axial spondyloarthritis. So it's a huge kind of burden, and it's kind of low-hanging fruit, if you know what I mean, in terms of being able to identify patients easily. You don't need any fancy additional tests to get them channeled to rheumatology. You just need the kind of awareness to be there, and for rheumatologists and ophthalmologists to work together to establish this diagnosis. It sounds easy, but it's probably more difficult to action.
And it's up to us to kind of speak out loud about the importance, especially in uveitis clinics, of taking a thorough medical history. Within patients we see in ophthalmology, sometimes there's because we rely a lot on examination, looking at the slit lamp, and we have all these ubiquitous imaging modalities, which are all very exciting. It's the advent of artificial intelligence and big data, and ophthalmology is certainly using this. So there's a very exciting future from that perspective, but there may be a slight temptation to forget or to not pay enough attention to that first element, which is to take a thorough medical history, which we do in uveitis clinic. And I'd like to think, both in the United Kingdom and around the world, we do aim to ask symptoms relating to Ankylosing Spondylitis, Axial SpA, chronic back pain, inflammatory back pain, buttock pain, morning stiffness. Certainly, we have a poster in our clinic to make sure that we do that, and also just asking about family history, and obviously determining age of onset as well. So these are things that I recommend to my colleagues when they're starting the uveitis clinics, and particularly in our emergency settings. So our emergency settings may be when these patients first turn up, and sometimes when the eye clinician's in a little bit of a hurry, they may not necessarily think of going through all of these things, but that's precisely the reason why myself and Karl are now, having this discussion in this podcast to just promulgate this message that don't forget to ask the history, because that can unlock the diagnosis.
I couldn't agree more, Nima. You've really hit the nail on the head there. It's really going back to basics in terms of, this is all about history taking. No fancy tests. It's about history taking to raise awareness and then prompt onward referral or appropriate investigations.
So tell me a bit more about that then. So what would those key questions be to ask patients with either presenting with uveitis or presenting with back pain? What would it you would be wanting clinicians to be asking, or what are those key symptoms you'd recommend they're looking out for?
Yeah, I think, well, I'll start with this. So the first thing you'd ask them is whether they suffer from back pain. So that's the first thing. And of course, a lot of people suffer from back pain, Lucy, at different points in their life. But what we're talking about is persistent back pain. And by persistent, we mean back pain that's going on for 3 months or more. So, that's a fairly considerable amount of time. So it's persistent back pain. It typically is lumbar or buttock pain. Sometimes it can be thoracic, but more commonly lumbosacral, kind of buttock area. Typically the pain improves with activity. So if you ask patients, is there anything that helps and does movement make a difference? They'll usually say they're better if on the move, and they don't improve with rest. So we kind of distinguish pain on the basis of whether it's got inflammatory or mechanical type characteristics. We're particularly looking for those inflammatory type characteristics, the things I've described. Improving with activity, not improving with rest. Buttock pain, pain that moves from side to side, we call alternating buttock pain. Pain that disturbs patients from their sleep. So it's the pain that kind of wakes them at 3 o'clock in the morning and they can't get back to sleep and they're tossing and turning. It's prolonged early morning stiffness, i.e. they feel seized up in the morning. And that's what I often say to patients. Stiffness, they sometimes difficulty, it's this sort of differentiating stiffness from pain. I say, do you feel seized up or tight in the morning? And that's what they often describe. And that often goes on for many, many hours before they limber up and feel that they're kind of as good as they're going to be. But they're probably never normal. And they've kind of probably reset their mind into thinking what renormalize normal, if you know what I mean, because they've often lived with these symptoms for a long period. And the other important point to mention about the nature of the pain is typically it begins under the age of 45. It should rarely begin after the age of 45. Now, that doesn't mean to say that the patient mightn't present till they're 65 with their episode of uveitis, and they may have had the pain for 40 years, but never had it investigated or never volunteered it or never been attended to or never been listened to. But typically it begins under the age of 45 and usually begins around the age of 30. And then there are other things we can ask. That's all you really need to ask. So like, I know time is limited in uveitis clinics, often the emergency department, people are queuing up outside and you have to go fast and furious to get through the work. If you have time, it's nice to ask about family history. It's nice to ask about things like peripheral arthritis. Have you had other swollen joints? Have you had heel pain, as in, enthesitis? Have you had swollen digits, swollen toes, swollen fingers? We call that dactylitis. Have you or anyone in your family had inflammatory bowel disease? And I'll say specifically Crohn's disease or colitis or ulcerative colitis. That's probably more impactful for patients. Has anyone in the family got psoriasis? Have you got psoriasis? They often won't know, but they'll sometimes say, well, I have this rash, but I'm not really sure what it is. Or they have hidden it and, the scalp scaly rash that they've got that they've kind of attributed to seborrheic dermatitis or dandruff is actually really psoriasis. So you could go into more depth, but I think the basic is chronic back pain, persistent back pain, beginning under the age of 45. That's the key question. And we don't need to overcomplicate it. That's enough. If ophthalmologists ask that question and then refer those patients who respond positively through to rheumatology, that's all we need. That's my view anyway.
Back to you, Nima. If we get our ophthalmology colleagues asking some of those key questions and understanding those key symptoms, what next then? What are those referral strategies? When do we refer to rheumatology? When should we not refer? How do we refer? What does that look like from an ophthalmology perspective?
Absolutely, yeah. I guess it does depend from place to place. In terms of what the uveitis setup is in any particular hospital or trust, and what the links are with rheumatologists. I mean, I'm only speaking from my own experience, but everywhere where I've worked, there's been a close link with rheumatology. Where I work in Liverpool, we do a joint clinic with rheumatologists, and it's very useful for just touching base and getting these patients seen early once we suspect, based on our history, that there may be undiagnosed ankylosing spondylitis, for example. As an ophthalmic physician previously, I would have sometimes, and I'd be interested to hear what Karl's thoughts on this would be. I might myself sometimes book imaging of the sacroiliac joints and the spine, either X-ray or MRI, magnetic resonance imaging. Nowadays, because I have that good link with rheumatology, I'd just email them or write a letter and just say, these are the symptoms that this patient has. Please, could you kindly see them for a comprehensive evaluation, given the clinical suspicion is high with these features, and I don't necessarily book the imaging myself, nor indeed even sometimes repeat bloods. Although as a uveitis screen, we would tend to do inflammatory markers and chest X-ray, for example, and one or two other core tests. If my suspicion is high based on the history, I wouldn't necessarily need to repeat those when I see them in uveitis clinic. But yeah, I'd be interested to see what Karl thinks, particularly about whether in the uveitis clinic whether it helps the rheumatologist if we book the spinal imaging.
I think it depends on what the local arrangements are, Nima. In our hospital, that sometimes happens, sometimes it doesn't. It's great when it does, because if the scan result is available by the time the patient comes to clinic, it's a kind of one-stop shop then, so you can make a diagnosis confidently on the day. If you don't have the imaging available, you can make an approximation, but you can't make a verified diagnosis until you've got that imaging available. So I think there are a number of things to consider, and I was discussing this with some colleagues this morning. At the moment, we've got standardized protocols practically in every NHS trust in the UK for imaging patients with suspected AxSpA. So it's very important, though, that the referrer states very clearly for the radiologist that they are suspecting AxSpA. And that'll be fine from ophthalmology. But if we open the floodgates and have everyone access to AxSpA imaging, unless they're very clear in their instructions, the patient might end up getting the wrong sequences and the wrong protocol. So that's a bit of a concern. Secondly, it's great then if the scan is reviewed by an MSK specialist radiologist. So when we request them from rheumatology, the scans in Norwich will all be reviewed by a specific team. My concern is that if we have scans requested from other sources, the scan might be outsourced, both for the acquisition and the interpretation of the imaging, and it may not be done by MSK specialists. So that could potentially dilute the whole service in terms of the quality. And I personally think ideally it should come from rheumatology, because then we'll have ownership. We'll review our own scans, and I think that will improve the diagnostic accuracy. So I would be in favor of leaving that to us, even though sometimes it might delay the diagnosis by an extra month or two. But in the bigger picture, knowing that, the mean delay is currently 8.5 years in the UK, and I'm not talking about, uveitis patients, I'm talking about the whole population of AxSpA patients. 2 months is very little in that patient journey. And I think it just improves the diagnostic accuracy of the whole process. So I'd be in favor of that approach. But again, it depends how local services are set up. And unfortunately, Lucy, there is no standardization, as you know, in the NHS in the UK. There's huge variation in practice.
Yes, absolutely. And I think that's definitely what I was hearing. There's a key thing in both of what you've just said there is around that focus on that multidisciplinary team working and how understand your own system, understand your own organisation and how that works well. But actually, when we think then about that multidisciplinary team working, how we really get that working, Nima, I know you mentioned doing some joint clinics, but are there other options? How does that work for you, Karl, in your place? And what is that range that we could get our other clinicians to consider?
So we have a combined ophthalmology rheumatology clinic as well. But actually, the focus of that clinic is very much on kind of patients with other systemic diseases, mostly vasculitis, and patients who are being treated with immunosuppressive therapies and advanced therapies like biologics. And there already are hundreds of patients in that network. So we haven't included the uveitis, kind of standard uveitis patients in that pathway, because it would just burst the bubble. And we kind of consider the uveitis to AxSpA pathway quite clear-cut, whereby we think in most cases it doesn't require the MDT sort of networking for all patients. Having said that, there will be a subset of patients perhaps with, really complex uveitis, sight-threatening disease, really difficult AxSpA, and we're trying to identify the optimum therapy. So for patients like that, we'll come together and we'll discuss those patients. But for the vast majority of patients who've got AxSpA and uveitis as part of the disease spectrum, I don't think the multidisciplinary team working is absolutely necessary for each patient. That's my view. But that's because of process and capacity, really, Lucy. I'm not saying it's not the ideal. It is probably the ideal, but I don't think it's realistic because there are so many of those patients. We in Norwich, we look after about 1,500 patients with AxSpA. So if we said 30 or 40% of them have uveitis, that's another 400 or 500 patients that we're going to have to find these combined appointments for. And we don't have the capacity for that. I don't know what your views on that are, Nima. In Liverpool, would you see all of your AxSpA uveitis patients in that combined network, or is it only the select group who are difficult to treat or difficult to manage?
No, we tend to, in our combined clinic, actually, most of our patients are uveitis, which affects the back of the eye rather than anterior uveitis. But patients who's been very challenging to manage because of the complications of uveitis, and for whom the severity of the flares has just been to the extremes that people could experience. Those are the ones that we might see in the joint clinic.
Same for us then, really.
What about those smaller centres, I guess, the ones that don't have that capacity? So what I'm hearing there is that it doesn't have to be done in an MDT clinic. So I think in particular for some of our listeners, they may be coming from those smaller centres where there's just not that capacity for that type of working. Do you both think that this can work through, relationship building, points of contact? Where do we start with that if you're in a smaller centre?
I definitely think relationship building, and it's not just doctor to doctor relationship. It's, allied health professional to allied health professional. It's down to the administrative staff so that everyone knows the process so that no patients fall through the hoop. So it's about team working across specialty working, and it's very much numbers of people rather than individuals. I mean, I think individuals can perhaps guide and give some, oversight, but it's very much a team within a team as well, if you get what I mean, Lucy.
Yeah, absolutely.
So, like, for example, one of the things Nima mentioned there was about signposting. And so we need to include this patient in the journey as well. So NASS have a great set of resources called Back Pain Plus. I don't know whether people will have heard of these, but basically it's back pain plus uveitis, think AxSpA. That's the messaging. So they have posters that you can place in patient waiting rooms. And patients then often drive the referral because, while they're waiting for their uveitis appointment, they'll have read, back pain and uveitis, think AxSpA. They may then pose the question to their clinician, and that might drive the referral as well. So the nurses in the ophthalmology department in Norwich have been hugely helpful and instrumental in driving patients to us because, they'll have identified the patient as they talk to them when they arrive in the clinic that they're suffering from back pain, etc. So it speeds up the whole process and just creates that extra, shall we say, safeguard, or not safeguarding, but it's the extra, little nut or bolt that just links that into a referral, which is what we're after.
Absolutely. And it's that key thing here, isn't it? Is that multidisciplinary team working applies to both specialty, different disciplines, but also, as you say, to our different clinical specialties, and actually the role that our administration staff can play in having posters up and signposting in that kind of way is so crucial to this, catching this group of patients that straddle across these two different services.
I think, Nima, you've mentioned something similar. I think you are using some poster to signpost patients as well in Liverpool, aren't you?
Yes, we are. Yeah, and it really does. It helps focus the clinicians, helps focus the patients as well. We often find the patients become experts in this condition and can help educate us as well. So having that kind of media around our clinics really does impact the patient journey. Yeah,
it's interesting to see the sort of top tips that we're putting across here. They're not high tech, are they? They're taking a basic history, looking at a poster in the clinic. So we're not talking about AI or high tech technology here. It's back to basics.
Absolutely. And we find that so often, particularly through this podcast. We're really fortunate. We find that it's simple things that can make a massive difference. And actually, for Nima and ophthalmologists to be able to identify a patient with an undiagnosed axial SpA condition presenting with uveitis, the difference that can make in their journey to diagnosis is just massive, isn't it? As you said earlier, Karl, we know it's 8+ years for patients sometimes to get that diagnosis. So being picked up in other clinics is crucial to us getting that time to diagnosis down.
And it's hugely fulfilling for us as clinicians and hugely rewarding for the patients, to finally have a verified, unified explanation for multiple symptoms. And it's just to see their eyes light up. That's a bit of a pun. Once they've been given the diagnosis, it's fabulous, and that's why we're all here, to try to do some good for our patients, help them along their journey. Because the great thing is there are some fabulous therapies available. I know we're not really going to focus a lot on therapy, but there are so many excellent therapies available for these inflammatory diseases now, which are life-changing.
And I think that's the key, isn't it? What we're trying to do is get the right diagnosis in at the right time, because then we can really support with treatment, and actually then we can have a difference to our life as a patient living with this condition. Kind of some of the simplicity of what we've been talking around in those solutions, the making good connections, asking the right questions, and it's not lots of questions. Taking that history as you described, Nima, is crucial, but then asking some core questions around the persistent back pain and age of symptom onset, etc. I think what we were saying is that lots of different disciplinaries can get involved in this. So we know particularly our nursing staff can get involved in helping with this diagnosis. Is there anything more you want to say around how we could support our nursing colleagues, or what we know about nursing colleagues' involvement in the diagnosis of AAU and axial SpA?
I'm a big advocate for a uveitis clinical nurse specialist, and actually, as a side note, I'm trying to get one in my current department, because I've worked with uveitis CNSs and nurse practitioners in the past, and they have a big role in, I suppose, the integrative and holistic part of the patients that we see in inflammatory eye disease, asking the questions that sometimes you might not think of asking when you see the patients in clinic, and just prompting other clinicians. So uveitis clinical nurse specialists, both in terms of liaising with primary care and support networks for patients, are very invaluable, both in terms of monitoring the patients with their disease and the response to treatments, and for example, monitoring the patients who are on biologicals or second-line agents. They can be very useful indeed. I do have ophthalmic pharmacists who work with me who really do help as well with our uveitis patients, but it's a different. So that, when it comes to the multidisciplinary team, I'm an advocate for inflammatory eye pharmacists as well, which also exists in different parts of the country, not just where I work. But I do think the clinical nurse specialist is very valuable, particularly now as we're getting more and more new treatments, both systemic immunosuppressive treatments and also treatments which are just honed towards the eye. For example, we're just starting with clinical trials looking at one of the complications that you can get with anterior uveitis related to AxSpA, which is cystoid macular edema. So specifically looking at challenging the immune dysregulation, which leads to the fluid which builds in the back of the eye as a consequence of inflammation and the release of inflammatory cytokines. So working on these kind of immune cascades locally in the eye, we've got a number of clinical trials going on, and the uveitis clinical nurse specialist, I think, can be key in terms of helping us recruit these patients and working within these teams with doctors and others. So yeah, there's certainly building the multidisciplinary teams nationally and internationally, I think, would be a very exciting step moving forward.
So if we then think about, obviously clinicians could listen to this podcast, but where else would we point our clinicians to? So I'm thinking particularly, where would we send ophthalmologists to try and get some help or practical tools and tips when they're thinking about identifying patients crossing between uveitis and axial SpA? Nima, do you want to kick off with where you might suggest?
I think Karl alluded to this earlier, but I would, and I do link to this when I get the chance, send patients to the NASS website, where there's toolkits for healthcare professionals, which are very useful for ophthalmologists. I think it's important just for ophthalmologists, not just uveitis ophthalmologists, because as we said, a lot of these patients will be coming in to our emergency eye care settings. So attending the meetings and just discussing how we go about diagnosing these patients and what treatments we go for and what the future for treatments will be is important. Later on this year, we are meeting up in Belfast to discuss anterior uveitis and particularly axial SpA. And I think I'll be speaking there alongside Karl and my colleague from London, Harry Petrushkin. So these kinds of events will be good. Just sharing uveitis and ophthalmology and medicine always benefits from just sharing what we know, sharing the challenging cases, collaborating. And I guess, we're fortunate in the United Kingdom in that we have our National Healthcare Service, and we have the opportunity, especially myself as a medical ophthalmologist, to always be in and around my colleagues and learn from them and teach them and learn from our patients. So I think just to continue driving this so that we're not working in kind of independent silos and forgetting that these conditions affect not just one part of the body, but multiple parts of the body is crucial.
I think in some of my reading before we did this podcast, actually, I saw there was a YouTube channel as well. We've got some uveitis comic sites, which have got some really helpful videos to try and explain uveitis to a simpleton like me, that helps make it really accessible.
They're brilliant.
The last one was co-created with NASS, and these are really nice kind of infographic videos which are made by medical students and junior doctors. University of Birmingham is where this group originates from, the comics, infographics and medicine group. And we always get feedback that the act of making these infographics really does help the students and the junior doctors learn more about uveitis. Unfortunately, ophthalmology, and especially uveitis, is a little bit of a scary topic for a number of people in medical school. But if we can, you will get it sometimes in your multiple choice questions and in your exams, but it won't be something that you're really often too familiar with. And I think it's important both for junior doctors and for medical students to get to grips with this entity, but also primary care GPs, because sometimes patients will be going to their GP first with what they think might be just recurrent conjunctivitis in the eye, but is actually the first manifestations of anterior uveitis. So yeah, not to forget the crucial primary care role with this and many other conditions.
Yeah, and as you say that, it actually makes me think, we know obviously primary care is crucial within this, but we also know that patients can play a massive role in supporting clinicians to help themselves. So, Karl, I guess asking you with your NASS trustee hat on, would there be any useful pointers that you think clinicians could give to patients in terms of this condition?
Yeah, I mean, NASS have a big education program that they run for patients it's multifaceted, and we've run podcasts and webinars on extramusculoskeletal manifestations for patients, and there's a huge amount of resources on the website. So apart from the NASS main website, which is www.nass.co.uk, there's also a site called Axial SpA, which is www.actonaxialspa.com. But essentially, that's a campaign we're running now and has been running since June 2021 to bring down the diagnostic delay. And there are lots of resources on that would be very useful for patients and clinicians. We've had about £1 million funding for that project, and it's gathering momentum. And one element of the programme will be working with allied health professionals and other healthcare professionals in ophthalmology, dermatology, and gastroenterology. So you'll hear a lot more about that over the next year or so. And going back to what Nima was saying as well, just to give another plug, the Royal College of Ophthalmology annual scientific meetings in Belfast, it's Monday the 20th of May. So if you want to come and hear more about this complex, fascinating disease, Nima and I and Harry Petrushkin will all be there on the podium. I'm more than happy to chat to any of you and perhaps help you or support you in terms of service development or delivery.
Amazing. That sounds great. And hopefully people will be able to come and pick your brains a bit more about it.
Of course.
So I think that we have explored what we think some of the problem is around this challenging axial SpA and AAU patients. We thought around some of the action. And so what I'm really keen to hear from both of you as part of our wrap-up is what's that one message you'd want to get across to listeners, and thinking that the majority of listeners for this episode will be ophthalmologists in particular. What is it that would be your key takeaway message you'd like to leave our listeners with in terms of what they could do next, or how they can support in the work that you guys are trying to champion at the moment?
I suppose just to go back to one of the first things I said, which is ask the questions. Don't forget that history taking is crucial in ophthalmology and medicine, and in so many of our patients, we get that diagnosis from the history. So do ask those questions, and do speak to your friendly neighbourhood rheumatologist if you have any concerns.
A simple message, and hopefully it'll resonate with everyone, Lucy. My message is, if you have a patient with acute anterior uveitis, ask them if they have persistent back pain. If it's been going on for 3 months or more, and it began under the age of 45, think SpA. So it's the back pain plus message. Acute anterior uveitis, chronic back pain, think SpA, refer to rheumatology.
I just want to thank you both so much for your time today. I've really enjoyed the conversation, and I really hope our listeners get as much out of this as I have done. Thank you so much, and we'll speak to you both soon.
Yeah, thank you, Lucy.
Thank you.
Bye-bye.
Join us next time when we'll have another guest episode from the Act on Axial SpA campaign. And in that one, we're going to be focusing on gastroenterology and the challenges around axial SpA in patients with inflammatory bowel disease, such as Crohn's or colitis. In today's episode, we've talked about how patients with acute anterior uveitis can often have inflammatory back pain, and it's critical to identify this early and refer to rheumatology when appropriate, so that both conditions can be managed in a coordinated way to optimise patients' health. Visit the NASS toolkit at www.actonaxialspa.com for healthcare professionals to read more and find tools to use in your clinical practice.
Room for Improvement is brought to you by the Aspiring to Excellence programme from NASS, which is sponsored by AbbVie, Biogen, Lilly, Novartis and UCB, and in partnership with BritSpa and the NHS Transformation Unit.